At this time, it is my pleasure to introduce you to Ashok Bhasin. Ashok, the stage is yours.
Welcome to the 14th International Thyroid Awareness Week. Today is May 25th. As you all know, today is the World Thyroid Day. Each year for 14 years now, we have provided education programs for the benefit of our global audience. Online webinars are the best way we can reach a global audience. Online today, we have people from Australia, in the Far East, Asia, Africa, Europe, and the Americas in the West. We want to thank Merck Serono, Horizon, Exelixis, IPSA, Immunovent for their support. Merck KGaA Germany has been supporting International Thyroid Awareness Week for past 14 years. And we also wanted to thank our host, Porto Novelli of UK, for hosting this program today. And as you saw, Marco is the one who started from Porto Novelli. So I am your host. My name is Ashok Bhasin. I'm president of Thyroid Federation International. I want to introduce now our speakers for today, Dr. Nancy Patterson and Dr. Larry Smith, an eminent endocrinologist from the USA, both are from USA, and are holding this webinar today. Thanks for their precious time and efforts in making this possible. First, I would like to introduce Dr. Nancy. Dr. Nancy Howard Patterson is the founder of Graves' Disease Foundation in USA and also part of the Thyroid Foundation of USA. She holds a PhD in counselor education from the University of Florida. She is a clinical specialist in psychiatric, mental health, nursing, and is a nationally certified counselor. Following her own battle with Graves' disease, and to our audience today, this is very important. She herself has gone through the Graves' journey, so hearing from her directly is something that is of a lot of significance. Dr. Patterson founded the Graves' Disease and Thyroid Foundation in 1990, and Dr. Patterson has received recognition from the American Thyroid Association as a pioneer in thyroid patient education. So to speak, you will hear today from the horse's mouth itself. Now I would like to introduce Dr. Terry Smith, who subsequently, after 10 slides, follows with Nancy. Dr. Terry Smith holds the Frederick G.L. Hithwell Professorship in Ophthalmology and Visual Sciences at the University of Michigan and serves as a professor in the University of Michigan Department of Internal Medicine Division of Metabolism, Endocrinology, and Diabetes. Terry has hundreds of publications in thyroid and Graves area and has also authored some books. So over to you, Nancy, and subsequently, Dr. Terry Smith. Over to you, Marco.
Hello, my name is Dr. Nancy Howard Patterson. I am with the Thyroid Federation International, as well as the founder of the Graves' Disease Foundation in the United States. I'm going to start with my journey through Graves' disease and thyroid eye disease. Back in 1987, I was driving home from the beach. I had just recently finished getting my PhD in stress management and how to manage it. And I'm driving home from the beach and my heart is pounding so hard that I can see my shirt bouncing up and down. And the part of me that had just finished her PhD went, "Oh, you're under too much stress." And the nurse in me, which I had been for several years, went, something's wrong. You need to go to a doctor. So the next week I went to a cardiologist who did a lot of tests, a lot of blood tests, and a lot of EKGs and things. And at the end, everything was, excuse me, relatively normal. But he said, "I want you to wear a heart monitor and then come back tomorrow. I have one more blood test I want to do." Well, and this was 1987. Back then, a heart monitor was as big as a laptop computer, and there was no way I was going to wear it. So rather than say, no, sir, I'd rather not do that, I just never went back to him. What I know now is the next day he would have done a TSH and I would have known what was going on. I went to another cardiologist who kept me for several weeks, and after I passed out on the walking machine, they sent me to an endocrinologist who did a TSH test. That's a thyroid stimulating hormone test, which came back that I had Graves' disease. He said at the time, there's 3 ways to treat this. We can do surgery, but you'd probably never talk again. And what I know now is that surgery back then was very clumsy. Now we have machines and things where the doctor can see what they're doing. Back then, they hoped they got your thyroid and didn't cut your vocal cords. But that was why he said you might never talk again. He said there's medicine, but it can give you leukemia. He gave me the wrong word. It could give you leukopenia, which was a low blood count. And then he said there's radioactive iodine, which is 100% safe. This was a Wednesday. On Friday, I had my dose of radioactive iodine, and that was it. The next week, I went back to my primary. He said, "How you doing?" I said, "Fine, but my eyes feel funny." And he immediately sent me to an ophthalmologist there. I was in Jacksonville, Florida, in the States, who sat me down and said, "You have what we call Graves' ophthalmopathy." They did not use the word thyroid eye disease 30 years ago. And he said, "We really cannot treat it. We don't know. We try to manage it. We manage it with steroids and simple things like ice packs and raising the head of your bed and some diuretics if there's too much swelling." And he's explained that it could last about 3 years in what he called the hot phase, and then it should settle down, and it could all get okay. What it did was my eyes continued to bulge. My vision was double. But we tried to manage it, and at the end of the 3 years, it did get quiet, but it was stuck in that position. My eyes were very bulgy. So he sent me to a surgeon in Atlanta who did the series of surgery, and everything was good. Then I went to, at that time, I talked to that surgeon and my endocrinologist, and I said, "Where do you get information? I don't know anything about Graves' disease." And they said, "There isn't any. There is no place to," and I said, "Well, there's going to be a foundation, and you're going to be part of it. Is that okay?" And they said, "Sure." So the next week, I had a client. I had a mental health practice, and a client that was an attorney who wrote up the papers for a nonprofit organization, and they were the vice presidents. So I would go to medical meetings, just 2 or 3 a year. And one time somebody said, "Who did all your eye surgery?" And I told him, and he went, "Wow." He pointed to all the doctors. I guess they were on a break. He said, "You see all these doctors?" And yeah. Every one of them was either trained by that doctor or trained by someone who was trained by him. My point here is I had good doctors from day one. There are people still today that spend years trying to find a doctor who even knows that they've got Graves' disease. or knows that they've got thyroid eye disease. They just miss it. They miss it because it's a rare disease. Thyroid eye disease is a very rare disease. And that's what this presentation is going to be about. We're going to talk about just the physical manifestations of Graves' disease and the physical and emotional manifestations in both Graves and thyroid eye disease. Here's the website and the email for the Thyroid Federation International. We've all got social media. Please get in touch with us anytime you want to. For Graves, the shorter symptom list are the systems that it affects, which is essentially every system in your body, is cardiac symptoms, reproductive symptoms, metabolism, muscles, brain, eyes, nervous system, psychological. This one doesn't have skin, but that's one. And so if you break it down and go to the doctor and present with a rapid or irregular heartbeat, or just say, I'm nervous and anxious and don't know why, I can't sleep, my eyes feel like they're bulging, I can't get pregnant. You usually don't say you have an unblinking stare. That's something that they notice. You mention, they can see a swelling in your throat, which is your thyroid, and it's called a goiter. And a thing called the thyroid, the Graves triad is a goiter, bulging eyes, and pretibial myxedema, which is on the next column of this list, which is itching on the legs. No doctor would miss that, but that you don't go in with that. If you go into a doctor with that, you've had it for a long time and nobody's caught it. People have intestinal problems. They have a difficulty swallowing because of the goiter. They're warm and hot and sweaty. They're hot. We usually call it hot when others are not. There's weight loss because your metabolism is so high. Considerable muscle weakness. And if you can get pregnant, lots of miscarriages in the first trimester. None of this list goes particularly into the neuropsychological issues. The quality of life with Graves' disease features a lot of fatigue, difficulty concentrating because you are constantly flooded with TSH. It's like having a really fancy car, putting it in park, and stepping on the gas and just running it, never taking your foot off the gas. That's why you can't sleep. It's why you can't think. It's why you can't remember. You worry about your job. Can I do it? Will they keep me? Will they fire me? You begin to get really worried and frightened about what else is going to happen. Everything seems to be falling apart. The emotional problems, the anxiety and the depression are caused by this excessive thyroid hormone, like when your foot's on the pedal with the gas. They are not personal failures, which almost everybody feels like they are. There's something wrong with me. I've done something wrong. That's not true. You are fine. It's the thyroid hormone that's messing you up. When you get to quality of life with thyroid eye disease, which may occur in conjunction with the Graves' disease or may not. There are people that have had it 15 years ago and now they've got Graves. There are people that have it 15, 20 years later and go, well, I had Graves 20 years ago. Why am I getting it now? Most of the time it occurs within the first couple of years in that hot phase with Graves' disease. There are a few people that don't have Graves' disease but have thyroid eye disease. They're both categorized as rare diseases, and they are separate autoimmune diseases, but they're both thyroid centered. A couple of years ago, there was a small survey done in Italy, and 80% of the respondents noted the following that were the most troubling to them. And double vision was the most troubling. The way they looked, the bulging eyes, the way people looked at them was there. Not being able to drive anymore, usually because of the double vision. The light sensitivity was one of the most disruptive. Not able to do the things they used to do, particularly fine, like embroidery. For me, it was weaving baskets. Not being able to read anymore, usually because of the double vision. What saves us on that are talking books. You begin to feel very isolated because you can't get out and you don't have many social activities. There are differences in what patients need, what families need, and what caregivers need. Patients experience all their symptoms and all their emotional things and their physical things. They're all in there. Families experience mostly the display of the emotional symptoms, and usually it's the negative ones. Graves does not make you a loving, sweet, caring person. It makes you a grump at best. Caregivers, physicians, experience the confusion of proper diagnosis because the things they give you are so many different things. The challenges of treatment, which treatment to choose and the follow-up, and the complicated and complicating physical and emotional symptoms, as well as the fact that each patient is different. So just because you took care of the last one and did X, Y, and Z doesn't mean you can do the same thing with the next patient that comes in. What patients need. Patients need a physician who's experienced in treating Graves' disease. A suggestion would be, if you're looking for a physician, when you call, ask the office manager how many Graves' patients this doctor sees. If it's 1 or 2 a month, that's really not who you need to see. You need to see one that, sees a dozen a week. You need a doctor who will listen, or perhaps has the time to listen. With so many regulations that cut their time down that they can spend with patients, that becomes a big difficulty. Patients need a doctor who will see them as a whole person in context with their life, as opposed to a thyroid and a neck and maybe some eyes. They need a doctor who will involve them in the treatment process. That means they're a team, that the doctor gives accurate and understandable information instead of in medical ease, and will refer them to support groups when that's appropriate. And in my humble opinion, that's always appropriate. Patients need support. They need it from the doctor. They need it from the family. They need the family to be involved, and they need to know that they're not alone, which gets us back to support groups. Patients need to understand that the doctors have to be concerned with many other medical things that can go on with Graves' disease that we have no idea about, but it can trigger a number of other things. What physician needs. Physicians need patients who trust them. If you don't trust your doctor, you might as well go get a new one. Doctors need patients who can give accurate information. For example, if you tell the doctor, I feel awful, that doesn't tell them anything. If you tell them, my eyes hurt all the time, that really doesn't tell them anything. Those are different than if you say, I'm only sleeping 2 hours a night. I get breathless when I walk up the 5 steps to my office door. I'm using drops 20 times a day. My spouse says my eyes are not closing when I'm asleep. Those are very specific things that the doctor can address and deal with. What families need is not on here, but they need information, and then they need it to be accurate information. Families need support. Good support groups break off and have the families talking to each other and sharing their experiences and getting support for each other. They need patience because it's very hard to stay patient with this person. It's just that is having a very difficult time managing their life. And they need communication from the patient and with the patient. It's a good idea to go with them to doctor appointments. You can help them remember what is said, and you can gain understanding and be able to ask questions yourself. My closing advice would be to, at the end of the appointment, when the doctor says, do you have any questions? And almost always we can't think of anything right then. You can say, what do other people ask? And I have never not gotten an answer to that question. And sometimes it's a very long and complicated answer that I had not thought of. Thank you very much for listening. Please get in touch with us. Here's more contact information.
Good morning, everybody. I have Dr. Terry Smith and also Nancy Patterson with me here. Dr. Terry Smith is an endocrinologist, and he specializes in Graves' disease. And Dr. Terry Smith is a professor at University of Michigan. Terry, the first question we have for you, and this is on behalf of Nancy that I'm asking, is how can a doctor suspect Graves' disease in patients?
Well, that's a provocative question you ask, Ashok. But first, I want to say to the audience how delighted I am to be participating in this, I would call it a festschrift for our dear friend and colleague, Nancy Patterson, who has long championed the unmet needs and how they may be met for our friends and neighbors who have Graves' disease and related autoimmune problems, and how we can make good headway both in the research laboratory and in developing new and improved medications, improved surgical techniques for Graves' disease and for thyroid eye disease, which occurs in probably close to half of the patients with bona fide Graves' disease. So now, getting back to your question of me, Ashok. So because Graves' disease affects the thyroid gland, it can present in a myriad of ways, and this can lead those doctors who encounter patients with early Graves' disease in a number of different directions in terms of establishing exactly what the problem may be. So the thyroid gland, as we have come to learn over the last century, produces several hormones, and we call them collectively thyroid hormones. And these thyroid hormones regulate almost every bodily function I can think of this early on a Sunday morning. And therefore, the symptoms and the physical signs that altered levels of these thyroid hormones might impose on the individual with Graves' disease. Typically, those with Graves' disease at some point during their clinical course will have abnormalities in the function of the thyroid gland, most frequently the production of too much thyroid hormone. But this is not necessarily the case in 10, maybe 20% of patients who never experience any excursions in the levels of their thyroid hormones, or who present and remain potentially hypothyroid or not producing enough thyroid hormone to maintain normal bodily function. So given the variety of presentations, it sometimes takes a very astute clinician to piece together all of the symptoms and the physical signs she or he encounters when examining the patient, and come up with the correct diagnosis of Graves' disease. Now, Graves' disease is an autoimmune process. And what does that mean? Well, what it means is that our immune systems, that is the function of the body that protects us against infection and cancer, and keeps us safe from harmful bacteria, viruses, all of the mischievous invaders in our environment. And sometimes, especially in women, but also in men, just not as frequently, this immune system gets a little carried away, I would say. That is, the immune function becomes exaggerated and misidentifies tissues in the body, organs, particular cell types, proteins, and other molecules as foreign. And this inaccurate, this incorrect identification of self as foreign can lead to a mighty defense against one's own body. And that is the case with autoimmunity. So while immune surveillance or host defense is an absolutely essential function of the healthy body, when overexuberant, it can lead to trouble. And that's what happens in autoimmune thyroid disease, like Graves' disease. And in the particular case of Graves' disease, the thyroid is provoked to become overactive in most cases. And as I mentioned just a few minutes ago, sometimes the thyroid becomes underactive. But whatever the abnormality, this is the proximate result of the immune system misidentifying the thyroid as being foreign. And we know that ultimately some of these autoimmune diseases will lead to the destruction of the thyroid. But other times, this overstimulation of the thyroid by the immune system simply results in long-term overactivity. Now, one of the peculiarities of Graves' disease, and actually the one that compelled me as a young medical student to think seriously about focusing on the thyroid as a professional activity, was the fact that not only is the thyroid affected in Graves' disease, and as I mentioned, in about 50% of patients with Graves' disease, the tissues around the eye, the upper face, the so-called orbit, that is the bony socket which accommodates the eye itself, those tissues become activated uniquely in Graves' disease. And what happens is that these tissues become inflamed, they expand, that is, they get larger. And what happens? Well, because the bony socket is fixed, that is, there's no give in that part of the skeleton. And so the tissues around the eye, within the orbit, push the eye forward and give a bulging appearance. And this too can lead to serious problems because it can compromise the nerve that conveys the visual image recorded from the retina to the brain. And this can then lead, this compromise of the optic nerve can lead to some loss of vision. The expansion can also lead to pain and discomfort and to the inability to move the eye normally. And we call this process thyroid eye disease. And while many of the underpinnings of Graves' disease affecting the tissues around the eye and those affecting the thyroid gland are shared. That is, they're identical. They have what we believe to be identical immunologic causes, they also have distinct features which need to be treated differently. So with regard to the overactive thyroid in Graves' disease, we use certain drugs, and the audience may recognize the names of some of these drugs like propylthiouracil, PTU, or methimazole. Sometimes to correct the overactivity of the thyroid, we advise the patient to undergo surgical thyroidectomy to remove the overactive thyroid. And a third option is the use of radioactive iodine to essentially remove the active thyroid gland by burning it out, if you will. And depending upon the specifics of an individual patient will determine whether medications, thyroid surgery, or radioactive iodine ablation is best. Now, with regard to the thyroid eye disease, which, as I say, occurs in about half of patients with bona fide Graves' disease, how do we treat patients who might suffer mightily from that problem? The thyroid eye disease can be relatively mild and be treated effectively with local measures like eye drops and keeping the eye protected from wind and direct sunlight, both of which can result in dryness of the eye and the tissues around it, leading to substantial discomfort in some cases. In more severe thyroid eye disease, that is moderate to severe thyroid eye disease, we sometimes resort to systemic medications. And the most commonly used medication for active or the inflammatory early stages of thyroid eye disease are steroids. And these have been used with some success for many decades. And they can, in many patients, reduce the inflammation, the swelling, at least temporarily, of thyroid eye disease. But some patients have much more severe and persistent thyroid eye disease. That is thyroid eye disease that progresses, that is associated with dramatic inflammation, a lot of symptomatology, excruciating dry eye symptoms, loss of vision, and despite the use of drugs like steroids, continues and results in permanent changes in the tissues around the eye, rendering the eye vulnerable to exposure, for one thing. That is that the eyelids in some patients don't drape the eye properly, and this can lead to substantial damage of the anterior surface of the eye itself. Other times, the bulging that I mentioned a few moments ago can result in disfigurement and in an inability to use the eye normally, to move the eye from side to side and up and down, can cause the patient to have double vision, which in my practice is among the most troubling aspects of thyroid eye disease. So in those cases where drugs like steroids don't seem to work well enough, there are surgical procedures which are employed typically by oculoplastic ophthalmologists to reduce the volume of the tissues within the orbit, and then subsequently, if there remains problems with what we call eye motility, or the ability to move the eye, double vision and all that inflicts, then what we call strabismus surgeons, who are also ophthalmologists, are very helpful in realigning the eyes to restore patients seeing one image. And then finally, surgery of the eyelids, if necessary, is not infrequently undertaken to improve the draping of the eye so that the eye is protected as it should be by the eyelid, so that individuals who had inadequate closure of their eyelids at the height of their thyroid eye disease can have this function of the eyelids restored. So that's just, I guess, a long answer to your initial question, Ashok, and I'll now uncharacteristically be quiet and get your response and that of Nancy.
Dr. Smith, I very much appreciate the detail that you went into. As much as I have heard over 30 some odd years, that's probably the most I've heard at one time and would have been very helpful at other times. What triggers Graves' disease? Do you catch it? We hear a lot about about stress triggers it. And I get into arguments about what stress is, but that's another subject. Did you find your slide?
So your question is what triggers Graves' disease?
Yes.
Well, that's a great question, Nancy, and one that may well have multiple answers.
For sure.
But a number of things have been implicated. For instance, the genes that we inherited from our forebears probably have a fair amount to do with whether or not we get Graves' disease and other autoimmune diseases during our lifetimes. So we call these genes in aggregate susceptibility genes, but genes are not the whole story. Maybe they account for 30 or 40% of the risk for developing Graves' disease. other factors probably derive from the environment. So infectious agents have long been implicated as potential cause for Graves' disease and Hashimoto's and other autoimmune diseases, rheumatoid arthritis, scleroderma, lupus, myasthenia gravis, multiple sclerosis. All of these may have some infectious component triggering the disease. We know that smoking tobacco is really, really bad, and that cigarette tobacco smoking probably represents the greatest modifiable risk for developing especially aggressive and severe Graves' disease and thyroid eye disease. And in fact, smoking has been implicated in other forms of autoimmune disease too. So, and we all know how difficult quitting smoking can be for most people, but it represents a huge challenge to me and my colleagues as practicing physicians to convince our patients that quitting tobacco use is a great idea. So in Europe, Nancy, just to quickly answer, I couldn't find the slide, but von Baesdow is the name that is frequently associated with what we call in North America Graves' disease, and Perry, von Baesdow, and Graves, three European physicians of the early 19th century, were among the first to describe this disease of the thyroid and some consideration of it being primarily a heart disease or a disease of other organ systems. But I suppose that at least in North America, Robert Graves, who was an Irish physician, apparently hired the right PR firm and won out as the guy whose name is most closely associated with the disease.
Well, thank you very much, Dr. Terry, for taking out this time for us,
yeah.
and Nancy, and thank you so much for putting this together. I know it is today, the Sunday, when we are recording this, but definitely our audience will be very happy to hear from a very eminent endocrinologist who is so well established in Graves and has so many publications and has also written books on that. So Dr. Terry Smith, from professor at University of Michigan, thank you so much. And thank you so much, Nancy. And thank you all for watching today. Thanks a lot. Okay, before we proceed further, I also wanted to announce that our second webinar on TED, that is thyroid eye disease, as part of International Thyroid Awareness Week, will be held on Saturday, 28th, 2022. And our speaker at that time will be Dr. Kelsey Rawls. She is a fellow at UCLA, California. And I can proudly say that she's a fellow Canadian from Alberta. And it's great webinar. on diagnosis, treatment, and surgical options in TED. She's done a very good job in putting all this together. And we will send you the link, and all of you will get the link in the next 24 hours. So please make sure you register, and you also register in advance so that, like today, it can be very easy to enter. And before I go further, I wanted to thank all our TFI board members, Beata from France, Nancy from USA, Linda from Italy and Spain. I'm not sure which country nowadays she is in, but Peter from Sweden and Netherlands, and Dr. Feridul Alam, Professor Feridul Alam from Bangladesh, and from Bohana from Serbia for the support and efforts. And again, I want to thank Merck Serono, Horizon, Exelixis, IPSA, Immunoment for their support. And again, Merck KGA has been supporting this for the past 14 years. Thank you very much. And again, thanks to Port Innovati UK for hosting this program. Now, we have had many questions, and we have noted down all those questions from where they are. Since it is very early in California right now, where Dr. Larry is, it's not possible to have him answer the questions today, but you will receive the answers by email directly to your questions from Dr. Larry himself, from Dr. Terry himself. And we will make sure you get all those questions in place, answered by him directly. We're sorry that was not possible today to make that happen, but we will manage. It's a global live webinar, so it's not possible to get everybody from Australia to Pacific area on board, but we will do that. And we have noted down all the questions. So once again, we look forward to seeing all of you on, and please make sure when you get the link, you can send it to your colleagues and friends, because this is going to be a very good presentation from Dr. Kelsey Rolfe, and you will know on diagnosis, treatment, and surgical options on TED. Thank you very much. And that's all from here today, from now, from Thyroid Federation International. And wish you all the very best and have a great day, and see you all on 28th of May 2022 for our second webinar in the series. Thank you very much. And this will, by the way, this is also going to be available on the YouTube channel of Thyroid Federation International. We will provide you that link too. Thank you, and bye for now. Any words from you, Marco, before we close off?
No, thanks. That's it. There are no raising hands and no questions in the Q&A, so we are good to go.
Thank you very much, and bye for now.